Shontay Delalue, and sorry if oh, perfect. PhD, MPF, currently serves as a senior vice president and adjunct assistant professor of health policy and clinical practice at Dartmouth College in Hanover. She is the senior strategist and thought partner working with institutional leadership on Dartmouth's key areas of focus related to diversity and global engagement. In her career, she has worked in admissions, academic advising, counseling, international affairs, as well as civil rights and immigration compliance in Maine, Alaska, and Rhode Island. And then we have Vinald Vinny um, Francis is a trained medical illustrator at Geisel School of Medicine at Dartmouth College. His primary focus is biological medical illustration, including surgical illustration and graphics depicting psychological processes. He also produces cellular and molecular illustration as well as biomedical graphics. They will be presenting Medical Misogynoir, graphic medicine as a tool to raise awareness of medical misogynoir across 3 centuries in the U.S. And with that, I will turn it over to you.
Great, thank you. Thank you for the invitation. We're going to jump in with our slides. I'm going to get them up. Okay, and everyone can see the slide? Great. So a little bit, and thank you for that wonderful introduction. In terms of my research, so I'm a senior vice president full-time at Dartmouth College, but I also have maintained my research since for several years now. And early in my research, I focused on African and Caribbean students' experiences with race in the U.S. because it was so different from their home countries. And then really did a lot of work on racial categorization in the U.S. from the 1790 census to the present. Currently, I have 4 research projects going on. One is exploring self-actualization through cultural immersion in West Africa for small cohorts. So I take 2 to 3, 4 people at a time and do work in the slave dungeons to understand how the history of the transatlantic slave trafficking impacts people's experience today. First generation low income students, understanding of financial planning. So that's a grant that I got from TIAA to really explore how low income students think about financial planning when in many ways they may not have the language to understand that based on their lived experience and family background. The next is the impact of grief and loss on a small New Jersey community. I grew up in New Jersey, and there seems to be a disproportionate number of people who have passed away at younger than 50 years old. And so I'm actually headed to New Jersey tomorrow to do is a qualitative study to understand the impact of grief and loss in that town. And then chronicling, I'll be doing in the spring, chronicling Black joy in the African diaspora, looking at the intersection of music and dance, and how, even though in certain communities there's been quite a bit of disparities, both in terms of health and wealth, how joy is still manifest. And then today focused on medical misogynoir, which is the presentation. Vinny, did you want to share a bit about yourself?
Sure. My name is Vinald Francis, and everyone calls me Vinny. I'm a medical illustrator. I trained in Cleveland at the Cleveland Institute of Art. Um, Currently, I am a medical illustrator for Geisel, and I do co-teach a medical comics course. Um, I also have a medical comic that I produce called Soda Pop Hospital that just addresses issues of underrepresented groups in the healthcare community. Um, for the purposes of this is what my role was as the artist and drafts person for the Medical Misogynoir comic.
Great, thank you. Can you all still see my slides? Okay, I'm finagling with the moving your boxes around. Okay, I'm going to go to the next slide. So our medical misogynoir comic, which we'll go into depth in a moment, is under a lab that I founded this past year, the Black Health and Wealth Equity Lab, which focuses on research and education. It's not a physical lab, but instead it houses all of the research that I'm working on and promotes examining and unpacking the systemic factors that impact the health and wealth of Black communities in the U.S. Amplifies what undergirds the community's ability to center joy despite the outcomes associated with health disparities and wealth inequality. My goal with that is not just to focus on the daunting statistics, but to really think about how communities persevere. Our first major project is medical misogynoir. So what is misogynoir? I've said that word a few times. It's a term that was coined by a scholar at Northwestern, Moya Bailey, in 2010. What it is the combination of anti-Black racism and misogyny, and that's directed toward Black women. So it is in the Merriam Dictionary, defined as hatred of, aversion to, or prejudice against Black women. The latest project of Professor Bailey happens to be also around medicine. It's Misogynoir in Medicine, a documentary. I'm not sure the documentary is out yet, but I've been tracking her work for a number of years. So where does medical come into play in terms of misogynoir? After doing some extensive research, would define it as the exploitation, negligence, and/or blatant disregard for Black women based on their race and gender when receiving medical care or treatment. Medical misogynoir is the deleterious effects. These are things that happen over a long period of time of the deeper level manifestation of anti-Black racism and sexism in medicine. There are terms like weathering you may be familiar with, allostatic load. So if you've had traumas over many generations, again, I do work in Ghana. I spend time in the slave dungeons understanding what enslaved Africans went through, and then all the way to the present and how those things impact people today. This is where that kind of deleterious effect comes into play. So why focus? Why a focus on medical misogynoir? What we really wanted to do was grapple with this persistent mistreatment. And the operative word there is persistent. Sometimes you can look at statistics and understand what's happening in a group. And unfortunately, some blame is put on the group, not really understanding the kind of historical context, social, political, et cetera, that has created the conditions that we see today. Specifically, we wanted to call attention to the healthcare experiences of women in the U.S. And explicitly name what is causing the staggering disease prevalence rates and mortality rates for Black women. That picture may be familiar to some of you. It's an illustration of J. Marion Sims with one of the 3 enslaved teenagers that he performed surgeries on. That particular woman on the table is Anarcha, and she was subjected to 30 experimental surgeries without anesthesia. And this was in the 1850s in Alabama. And again, you may know his name because he was then named the father of gynecology. But imagine the father of gynecology did horrific things to enslaved women. The 2 women peeking behind the curtain are Betsy and Lucy. And this is all documented historically that these were the women that he did the bulk of his surgeries on with no anesthesia. So in terms of a framework that we use to kind of focus our work from the research side of the house, I used Tricia Rose, who's a professor at Brown University. She just recently published the book Meta Racism, and that really refers to this kind of typical and sometimes ubiquitous nature of the way in which racism and the systemic and larger system works in the United States. One thing that she said that was really compelling for the work that we do, because we are combining art and research, we need to make much more room for compelling stories. And we feel like doing a medical comic is a compelling story that reveals the reinforcing impact of systemic racism on the lived experiences of those who have experienced the brunt effects of the systemic things. This slide really just lays out the prevalence rates of major diseases across 3 racial groups in the United States. And you'll see that for Black individuals, their highest prevalence rates in heart disease, stroke, diabetes, and HIV/AIDS. You'll notice that the prevalence rate for cancer is slightly lower for Black individuals as compared to white. But however, the mortality rate is higher. And so that's a question that we need to interrogate and ask them questions why. One of the things that we want to do, our goal with a medical comic, is to really answer what are the narratives behind the data, right? Data is important. It helps drive a lot of our work, but there are actual people behind these numbers. And what are those stories? What's embedded in those stories? So as we gathered information for our first comic, certain themes came out. One, medical mistreatment is systemic. It's something that has persisted over a long period of time, unfortunately. Medical exploitation has occurred for centuries, particularly in this country. And the medical myth persists that Black people have a higher threshold of pain than whites. There are research on pain tolerance, who gets access to pain medications when they present with pain in an ER setting, and those kinds of things. So we have deemed this is a persistent problem. And so we don't want to think of it just in a snapshot of what the data says today, but over a long period of time. So one example of the kind of statistics that we were grappling with is that a Black woman with a terminal degree, such as myself, I have a PhD and an MPH, has a higher maternal mortality rate than a white woman with less than a high school diploma. Why is that? The maternal mortality rate as of 2021 for Black women was 69.9 deaths per 100,000 live births, which was 2.6 times higher than that of white women. And there has been lots of work. I have a good friend at Tufts who does a lot of work on Black maternal health, and many people across the country who have been grappling with this issue. We have seen some good direction in terms of lowering it, but it's still a big problem. And then there's the persistent medical myth. So in a study in 2016 of medical trainees, half of the trainees believe that Black people are not as sensitive to pain as white people who were less likely to treat Black people's pain appropriately, right? So this is combining two things. You have J. Mariamson's in 1850s and then medical learners in 2016 still believing that Black people have a higher threshold of pain than white people. So this is a long time of really needing to address this myth that has a great impact on the Black community. That drawing in the middle is a part of the comic. It was done by Vinald, and he'll be going over the comic in a moment. This is just another example of some of the health statistics that we use to undergird our work. Life expectancy at birth, infant mortality, maternal mortality, and the numbers are staggering. And so we wanted to be able to share this kind of information in a way that we felt was palatable. So before I turn it over to Vinny, graphic medicine as a teaching and learning tool. So we wanted to explore medical comics, which is another term for graphic medicine, as a means to share complex medical information in a concise and palatable way. We wanted to consider the ways in which medical learners could be introduced to this information, so that hopefully, as they entered into the medical field, they can start to address some of these issues that plague from a systemic standpoint. We researched the medical mistreatment of Black women that dated back to the 1800s all the way through the 2000s, so 3 centuries. I'll now turn it over to Vinny.
Hello. So the three characters used in these stories are based on historical figures and facts. Mabel from 1850 is based on Anarcha, Betsy, and Lucy, who you saw in the painting previously, who were subject to medical procedures without their consent, specifically operated on without anesthesia by J. Marion Sims. Maddie from 1950 is based on the Ralph sisters, who were sterilized without their consent in their childhood. And Missy from 2050 is based on the case of Serena Williams and complications during childbirth that were ignored. Okay, to the next slide. To speak to the process of creating this work from an artist perspective, the first step was creating a script around the themes we chose. I then created storyboards using reference photos. We decided on the text first and built our panel compositions on the placement and size of the speech bubbles. After that, several rounds of drafts follow where we make edits to both the art and text. We decided to express the pain of the characters in a graphic fashion, using facial expression to convey the raw emotions. A central theme of this issue is pain, and our first story seeks to address the persistent myth about Black women having a higher threshold of pain and show that they do experience pain. This is an intermediate draft of Mabel's story. Here we are using vintage tones to convey how long ago these events took place. We also chose to integrate informational panels into the comics themselves. The panel, the fourth panel of the character's pain expression, is featured prominently in each story. In Maddie's story, the next one, we use color again to convey the passage of time and to link scenes together. We used publicly available photos of the real individuals impacted, the Rel sisters, to reinforce that these are actual events from US history. The next story is Missy's story from the future. Here we use a slightly different palette and illustrate what a highly resourced and educated Black woman still faces despite access to quality medical care. I use subtle graphic cues to highlight the main character and indicate her emotions. By placing it in the future, it leaves the reader with the question, will this treatment of Black women in healthcare settings persist? Back to you, Shontay.
Thank you. So the future of the work, we are working on the second series. So we launched we got an arts integration grant. Currently the comic is in hard print only. And we can work with Jillian if people want copies. We have a grant to distribute them, and we'd be happy to get copies to individuals who are interested. We are working on a digitized version. We know it can go much wider with that, but there's some steps that we're taking to ensure that we can do that soon, hopefully by the end of this year, if not well before. So our next series, it will be focused on women in the who were captured in the continent. So Vinny and I have had the opportunity to go to Ghana together. And so he has the kind of visual sense, and then I will be adding in the research components. One of the characters will have been captured from inland. The second character would have been in the slave dungeon in Cape Coast of Ghana. And then the third character on the actual ship in the Middle Passage. Again, to really set the tone that this is something that's happened for a long time. And then subsequent series, we have a whole list. We plan to just keep going. We'll focus on cancer. One will focus on maternal health. One will focus on mental health, etc. So who is the audience? We want to engage health learners, medical students, nursing students, public health, etc., to really interrogate structural racism as connected to historical and present day medicine. And of course, we know we can't reach everyone. That's a limitation, but we'll certainly do our best to get it into medical libraries. We're talking to people both here and abroad. We presented our work in Ireland at the Graphic Medicine Conference, and we got some good contacts of people in the UK as well. So medical misogynoir continues to cut Black women's lives short. And we believe that Black women, Black people, deserve long, healthy lives filled with joy. That's just a bit of our sources that we used, and I'll stop sharing and open it up for questions.
Thank you so much. That was so powerful and so important to the work that we all do. I definitely want a copy of that, and can help anyone else get a copy as well. It does look like we have a couple questions. Marjorie, do you want to come off mute?
Can you hear me?
Yeah.
Thanks. Great. Thank you so much. This was so powerful. I feel like I just had the best lecture since graduate school in womanist ethics. And I'm seeing the mothers of womanist ethics that you continue to build on. And I thank you for bringing these narratives forward, and the drawings are spectacular. If this question is outside of this scope, please just pass. We gather so many patient narratives, and we system-wide through our BIPOC book club here at DH, which has 15,000 employees, we gather even more narratives. We don't know what to do with them. Again, the power of publishing. And again, we're, I think in some ways, unethically limited with HIPAA in the healthcare setting from getting some of this stuff forward. So if you have any comments about that, and thank you so much. And we will be bringing your work into our book club. So grateful.
Yes, thank you. Thanks for that question. And I'm gonna have Vinny help too. He's steeped in other projects with some physicians at Brown in terms of narratives. And so, I mean, from my standpoint, when you go through the IRB, this is why we have an IRB, as long as it's approved, like so if we were to use individual people, that's not publicly available data, we would be happy to partner and go through the RIB and gather those stories. Because what we recognize is that that's what's most powerful, and that's what people remember, and that's how you start to change behavior. We presented just here on campus at the college, and one of the professors, who's a full professor, was in tears, and she said, "This is my story." Right. And that's a person that I'd want to get that story out if she was willing to, right? And so that's what my recommendation would be, as long as it is approved through our IRB. And then, of course, the hospital IRB and considering HIPAA and all those things. Vinny?
Yeah, from my perspective, I think that that is, to me, the most powerful thing about medical comics, graphic medicine as is known, is that it brings about perspectives that aren't normally considered. And it's much easier to take in this format than, say, a wall of text. When you have the dynamic combination of text and images in this accessible format, it makes it easier for us to take in some of these heavier subjects, some of these difficult things to read about and process them. So, my personal mission when it comes to graphic medicine is to tell the stories that are untold from different aspects of our healthcare community, patients, but also the loved ones of patients, uh, the staff, the caregivers themselves. All of these perspectives make up our healthcare community, and we don't hear a lot about, for example, what the loved one of an ICU patient goes through. And and I can say with certainty that all of us have been touched by the medical system in some way. We can't escape it, just being human. So there are a lot of narratives out there that I think would be beneficial for our community to have empathy. When I worked in a hospital, we regularly had Schwartz rounds where the people who worked were able to just tell these sometimes traumatic, sometimes inspirational stories, and us as fellow healthcare workers were able to support them and listen and be in community. And I think I want to promote that. So, absolutely, this is the perspective that I'm trying to push.
Thank you. So many comments and thoughts and connections and what can we do? And I could spend the next hour just talking about ideas. But Father Sam, one of our chaplains here at DHMC, wrote in the chat, thanking you for your wonderful presentation and insight, a cognizance of the past and present regarding inequality and mistreatment of a different race. Do you think that humanity could ever do away with discrimination in treating one another?
Oh, Father Samuel. That's a hard question. And I'm gonna answer it honestly, but with hopefully an inspiration of hope. I lived in Maine. I grew up in New Jersey, but I went to college in Maine. And at the time, Maine was the whitest state in the country. And people mistreated and discriminated against French Canadians. And that was my first lens into humans are going to find someone, right? Because I identify as a Black woman, that tends to be what I see, and that's my lens. But being in an all-white space with very few Black people, I saw that, okay, it was either the Penobscot folks in Old Town or it was French Canadians. It was like somebody was always put on the bottom, which is very unfortunate. What I think we do have the ability to do is unlearn those things, right? And we have the capacity and the ability to do that, especially with our technological advances. And so there's no reason why we have to stay stuck there, right? I think there people will continue to do it, but I want to believe that the majority of us can take that narrative back because this is about narrative and telling the truth and letting people's lived experience guide how we see one another and not the socialization and records that we're told about individuals and groups. And so that's where the hope comes in for me. After living in Maine for many, many years, I found it cathartic to tell my story. And I had people return back to me years later, remembering something that I said and being really honest and saying, you're the first Black person I ever met, and I didn't realize how many stereotypes I had about you. So even though we may be socialized as a human race to see each other in a particular way, we have the ability to undo that. And so that's where I'm going to put my time, energy, and effort